Well, there are many new drugs have been granted approval, each utilizing different approaches, continuous or time limited. So I'm eager to hear your thoughts on these strategies and initiate the cordial discussion about advantages, disadvantages of continuous versus time-limited therapies. So to delve deeper, let me start with a particular example, and the first question is going to go to Gilles, with my revenge. No, you already mentioned that. That's why I'm alluding to you. You already mentioned that we will have two bispecific immunotherapy for the LBCL. One of them is continuous, glofitamab, and the other one is the other way around. Glofitamab is going to be time limited, and epcoritamab is going to be continuous until progression. So, what are your impressions on this matter? Do we have to give continuous therapy? We have to assess the response at some point. What are your thoughts on that?
Am I supposed to talk here on DLBCL or on CLL?
No, DLBCL. Yeah, the topic was lymphoma and CLL, time limited versus continuous. So I started with.
I'm sorry about that. Well, I think for me there is a concept that DLBCL is a curable disease in the first-line setting. Probably we should achieve cure also in the second-line setting. That's the objective. And that for this reason, no regimen or no approach have been proving the benefit of, prolonged maintenance of any drug. So I think I will always favor time-limited therapy in these circumstances. Having said that, maybe two small nuances. The first one is that we have learned with CAR-Ts that this is a live drug that persists in patients for months and sometimes years. We don't know exactly what is important in the LBCL. We know in ALL that, if you lose the CAR-T within 1 year, you have exposed to a very high risk of relapse. This may not be true in the LBCL, although, data are scarce still. So there may be an optimal exposure to this immunologic pressure for our patient. Having said that, I think that when a patient is in CR and you reassess the CR after 6 months, whether you use an antibody, a bispecific antibody, some form of combination of immunotherapy, and probably everybody knows what I'm referring to, I think it's very hard for me to justify to further pursue a treatment in a patient. However, there are patients that had failed 3, 4, 5 lines of therapy and suddenly achieve a CR with another regimen. And maybe these patients are interested in continuing therapy because they feel that this is the only thing that works. And if this is tolerable and widely acceptable, I'm thinking about one of Alison's patients who is over 90 and had failed many lines of therapy and continued to receive an anti-CD19 antibody. Well, why not? And as long as this is tolerable, this may represent maybe the best option to avoid any new treatment that the patient may not be able to receive anymore. Whether the same thing will apply to bispecific, I think it's too early to say.
Yeah, thank you. Alison, can you comment on that? What is your thoughts or continuous or time-limited bispecific or?
No, sure. I mean, the patient that Gilles is alluding to is a patient with primary cutaneous diffuse large B-cell lymphoma leg type who, as he mentioned, is 91 years old and has had actually multiple lines of therapy with our mini-CHOP in the beginning and our GEMOX, and he had radiation therapy, CNS-directed therapy, and when he relapsed, he actually had a complete response to lenalidomide plus tafasitamab, and actually, I'm not comfortable stopping therapy. It had actually been about 2 years now on just single agent tafasitamab, and I actually think he probably would tolerate other therapy if he needed it, but I don't want to take a risk. And I'm facing that same situation for patients with multiply relapsed Hodgkin lymphoma, where I certainly, I have many patients that I'm taking care of that are on long-term checkpoint inhibitors, and I have, if they're earlier in their course of relapse refractory disease and they have a complete response, I would try to stop therapy. But for many of these patients where this is we've gotten their disease under the best control we've ever gotten, and they're living, a good quality of life, I'm uncomfortable stopping therapy. But certainly in earlier stages of disease, I think that trying to limit therapy and seeing if we can get patients off therapy is certainly what the goal should be.
Okay, thank you. Thank you very much. Yeah, there was some.
I can interject here. I think because I think what Gilles and Alison is really touching here something very important. Because sometimes we can consider those time-limited versus continuous therapy as one size fits all, but it's really depending on the clinical situation. In a relapse refractory setting with the very limited treatment options, we are sometimes inclined to do that because we do recognize potential benefit of the continuation of therapy in those patients who have very limited options otherwise. This is to contrast with some of the experience which we have, particularly with PI3 kinase inhibitors and combining with CD20 antibodies, and in indolent disease where a continuation of therapy was actually associated with toxicity in earlier lines of therapy, right? And partially this is because in those patients, in case of the progression, they would have other options as well. The key question here, which everybody worries about maintaining those patients on continuous therapies, what would happen if you stop? If you re-challenge later on at progression, would they have the same response? And that's unfortunately the question is going to be hard to answer for the clinical trials. And I think here as a community, if we can work on the real world data studies, kind of trying to assess the sequence and those responses at the re-challenge, is something which could help us, because if we knew that in your case of the patient maintained on tafasitamab now, if you stop and there's a progression, reinduction would work, you'd be much more comfortable to do that. But right now, there's really no evidence to support it, and that's a major clinical dilemma.
I fully agree. I think one of the important concepts of time-limited therapy is the possibility to retreat the patient, and that supports the use of stopping therapy. Another argument is the genetics. At least in CLL, one of the arguments to use a time-limited therapy is the development of resistance to the therapy. Andy, do we have data on resistance to biospecifics? You are a fan of biology of lymphomas.
Yeah, I think that's really interesting. Of course, this is an emerging field which we know very little about what the biology looks like at relapse, having failure of biospecifics. I think the whole concept of whether to have fixed duration or continuous therapy is one that we like to think as physicians that patients would prefer to have fixed duration therapy, but actually in patients who are being treated for multiple refractory or resistant diffuse large B-cell lymphoma or even Hodgkin's, they recognize that the stakes are high, and actually very many patients are, even though we think we'd like to offer them fixed duration therapies, are actually very comfortable with continuation therapies, and they worry about the risk of failure with withdrawal. I think my concern, as we understand more about the bispecific fields, and we have people who are on continuous therapy for prolonged periods of time, because we've seen some remarkable durable responses with bispecifics in DLBCL, is about the toxicity and the potential cumulative toxicity from these. And I think that's going to be a story that will emerge, as time goes by.
Yeah, that's important. We are seeing new drugs administered continuously with the results presented at 1 year or 2 years. And we are seeing that we have the experience of PI3 kinase inhibitors and AKT inhibitors as well, where the toxicity is developing after 1 or 2 years. So the short-term results are not good enough to evaluate the toxicity of this continuous. I have to confess that I have a patient with blastic mantle cell lymphoma reviewed by the God, so Elias Campo. This is a truly blastic mantle cell lymphoma that we administered. Our CHOP was 70-something, then 2 years of rituximab because we didn't have anything else. And we decided to continue the rituximab for 10 years. I'm a bit ashamed of that, but the patient is and now it's free of rituximab. It's 90-something, disease-free of aplastic cell lymphoma. So he came to my consultancy with the Spanish book of hematology. With the chapter was written by me, looking at the curve of aplastic. It was a disaster. No? It was 2 years median survival. So he's alive and he's very happy. So I'm a bit ashamed of explaining that I missed 10 years of rituximab. But I don't know if you have this kind of experience. I know that Martin, that left the meeting, had some experience similar to that. But I was wondering if you have experience giving these continuous monoclonal antibodies in your practice. No?
Francesco, if I can comment something. So I think that you have raised a very important point. I think that the patient view is very important. And it's a different if you are discussing with a CLL patient and with a relapsed refractory diffuse large B-cell lymphoma patient. So I remember, we had a significant number of the glofitamab treated patients, but 2 of them insisted to continue with the glofitamab over the 12 dose because they were too afraid that the disease could come back. And regarding the rituximab maintenance, we have the same experience. So I have one patient we discussed. It was not in the study. We have the highest number of the rituximab maintenance infusion we did was a 96 in one patient, the similar age. But it was in the study, it was given by the sponsor, but then we had some problems with the reimbursement. And I convinced one patient to stop the rituximab maintenance, and he progressed within half of a year. So it's a difficult. I think that the patient view in this field is very important, because if they do not see any possible chances in the future, it's very, very difficult to discuss with them.
In CLL we have a huge debate on time-limited versus continuous therapy. Astrid, you're treating CLL patients as well. What are the factors helping you to decide continuous, let's say, venetoclax or venetoclax versus BTK inhibitors?
Okay, so I think that is a challenging point, and in my opinion, in my personal experience, most elderly patients don't care about doing continuous treatment, and they would rather prefer to do BTK inhibitors rather than having a IV infusions and having to be admitted for venetoclax. So most of my patients, when I show them the 2 possibilities, even though we have the bad side of having continuous therapy, most of them will rather go on to continuous therapy and have an excellent quality of life. And as mentioned before, most of them are not complaining about continuous therapy with BTK inhibitor. I'm talking about elderly patients, and they have a very good quality of life. So I think the challenge is in young patients, and as said, in diffuse large B-cell lymphoma, the big point here is the possibility of responding to a new therapy when they have a limited time therapy. So I think we do have options in CLL for a further line of treatment for young patients who do have limited time treatment.
Thank you, Astrid. One of the factors we are considering, at least in CLL, is the genetics, the mutational status, and p53. Kieron, you already alluded to the problem in US on this genetic testing. Are you considering those factors in deciding the therapy in CLL patients?
Sorry, was that for me or not? I didn't.
Yeah, it was for you, yes.
This is in patients with CLL? Are you asking? Yeah. If the FISH characteristics, so I think those patients who have a 17p deletion or p53 mutation, they probably do better with a BTK inhibitor, but the data is still ongoing and changing all the time, and it may change more, but I think that's my impression right now. If they have a 17p deletion or p53 mutation, they get a BTK inhibitor, and for those that don't, I think there isn't a standard between obinutuzumab, venetoclax, or a BTK inhibitor.
Mm-hmm. Yeah. Okay. What about south of the world, Miles?
Look, I agree totally with what's been said about the age and look at the patient first, get the vibe from the patient about what their expectations are. Look, I'm in Melbourne, the centre of venetoclax and combination therapies. It's pretty obvious to know what most of the average patient would get in Melbourne. I think it's clearly for most patients who we feel physically are up to it, we will tend to give venetoclax obinutuzumab up front as their frontline therapy. Obviously, clinical trials, recognizing that the issues of it's easy to give at a big centre, but there's lots of education that needs to be done in patients, in people who are not familiar. And I think that is the education is the key thing in the short term.
Okay, so I think we can. I have a message. I think we have to wrap up this section. So I think one of the important messages taken into consideration, again, like in lymphoma, the patient and the performance status and desires of the patient, and also, if you can, the genetics to decide, at least in CLL. And for the lymphoma, there's still a huge debate what to do. I didn't mention the pola-benda versus tafasitamab, lenalidomide. One is time limited, the other one is continuous. So there's a huge debate on that. So thank you very much. It was a pleasure to share this friendly discussion. Thanks.